Three, two, one. We are live now. You can go ahead, sir. Thank you.
Hello and good evening, everyone. Welcome to the Expert CrossTalk, organized by Pinnacle, a division of Lupin, on the topic Empagliflozin, multi-benefits and multi-indications by multi-mechanisms. To talk on the topic, we have two esteemed experts, one from cardiology and endocrinology. So from cardiology, we have Dr. Kapil Virpariya, and from endocrinology, we have Dr. Kunal Thakkar. So Dr. Kapil M. Virpariya is a consultant interventional cardiologist at Oakard Hospital, Rajkot, Gujarat. Dr. Kapil is involved in a lot of research work and he has published them in various national as well as international journals. So also presented the research work in various conferences. I would like to welcome Dr. Kapil. From endocrinology, we have Dr. Kunal Thakkar. Dr. Kunal is a consultant endocrinologist at Sterling Ramakrishna Specialty Hospital, Gandhidham, Gujarat. Dr. Kunal has authored many publications in national and international journals based on the various research work he has done. Dr. Kunal is also a speaker on various endocrine topics in conferences, has also presented his research work in various conferences and other platforms. I'd like to welcome Dr. Kunal Thakkar. Now, without much delay, I would like to hand over the session to Dr. Kunal Thakkar for his perspective from endocrinology. Followed by that, we will hand over the session to Dr. Kapil for his perspective from cardiology. So, without much delay, Dr. Kunal Thakkar.
Thank you so much, Dr. Lokesh, for a warm introduction, and thank you, Team Lupin, for this opportunity to be involved in this scientific session. So, as Dr. Lokesh said, that we are going to discuss today much beneficial and a very commonly used drug, anti-diabetic, and now it's been found to have other indications as well that we are going to discuss in this. That is empagliflozin, multi-mechanisms, multiple indications with multi-benefits. So as is evident, I am going to speak on the endocrine or the diabetes related perspective of empagliflozin. And to start the session, sorry, I forgot to put in the view mode. Okay, so to start with, we know that SGLT2 inhibitors, they modulate a range of the factors related to cardiovascular risk. Now, let me tell you that empagliflozin, including other SGLT2 inhibitors, they are known to reduce the cardiovascular risk in diabetic patients, especially risk related to hospitalization for heart failure that we are going to see in some of the detail. But what are the mechanisms or what are the possible hypotheses behind the improved cardiovascular protection with SGLT2 inhibitors? So according to this particular study published in 2015, these are the various pathways proposed that lead to cardioprotection with the SGLT2 inhibitors, some of which include reduction in the blood pressure and arterial stiffness, albuminuria reduction and the nephroprotection, decrease in the glucose and insulin that we know, reduction in uric acid. Effect of SGLT2 inhibitors on lipids and lipoproteins is somewhat debated, and they are known to increase the LDL cholesterol as well as HDL, reduce triglycerides. But many of them have said that the cardioprotection produced by the SGLT2 inhibitors it may be independent of the lipoprotein changes. Reduction in the oxidative stress is one of the mechanisms, along with the reduction in the body weight, and decrease the sympathetic nervous system activity in some of the research papers which has been quoted. And other than these, there are many other novel pathways which are unknown as of yet to produce cardiovascular benefits, but they are in vitro studies, they have been shown to have some cardioprotective mechanisms and that lead to ultimate benefits in terms of cardiovascular risk reduction with SGLT2 inhibitors. So these are the parameters on the left side. If I put the laser pointer here, yeah. So on the left side, these are the parameters which are related to heart failure risk reduction mechanisms. So whenever we are treating a patient with chronic or acute heart failure, so what we want to achieve in that particular patient to reduce the risk of recurrent hospitalization for heart failure. So these are increase in the natriuresis, increase in the kidney function and cardiorenal physiology, reduction in the preload, afterload, and left ventricular wall stress, and reduction in the interstitial edema in the pulmonary circulation. So by achieving any or more of these mechanisms, we could achieve the treatment or prevention of the heart failure in these patients. And right side are the medications which are commonly used to treat or prevent heart failure in diabetic or non-diabetic patients. So just to brief, AC inhibitor or ARBs, these are the classes called angiotensin receptor with nitricillin inhibitor, beta blockers, mineralocorticoid receptor antagonist, that is spironolactone and eplerenone, diuretics, and recently SGLT2 inhibitors. So it has been marked in the table that at what mechanisms all these drugs are acting. So many of the drugs are acting at some or the other mechanisms, but we can see that SGLT2 inhibitors, they are targeting all the 4 parameters related to heart failure in any of the patients. So other than acting on all the 4 parameters related to heart failure, it has been shown in multiple studies that the beneficial effects of these SGLT2 inhibitors may actually complement and improve the effects of these mainstay heart failure medications. So in addition to these medications, the SGLT2 inhibitors have been proven beneficial in reduction of the heart failure risk and prevention of heart failure in patients. So if we see available SGLT2 inhibitors in our practice today, and according to the first study published for that particular category or that particular drug in the SGLT2 inhibitor category, so first study for dapagliflozin published in 2008, then in the same year remogliflozin study, then canagliflozin came in 2010, and then EMPA in 2012. And these are the studies with more than 500 disease-related events in each of the studies. So what are the mechanism? What is the mechanism of action of SGLT2 inhibitor? We know, first of all, this particular mechanism is for the glycemic benefit or the reduction in the blood glucose and the HbA1c improvement. What is the particular or the predominant mechanism? So we know that SGLT2 are the receptors located in the proximal convoluted tubule of the kidney. And on an average, diabetic as well as non-diabetic, as a normal, we are known to filter more than 180 grams of glucose per day through glomerulus. So now this 180 grams of glucose, when it comes to proximal tubule, almost all is getting reabsorbed by the SGLT2 inhibitors 90%, SGLT1 10%. So in normal conditions, non-diabetic conditions, almost all of the filtered glucose through the glomerulus is getting reabsorbed into the bloodstream. So that is why in normal circumstances, we do not have a glucose in urine. So we do not have glucosuria. So the mechanism of action of SGLT2 inhibitor is inhibition of this predominant SGLT2 receptor in the kidney or in the tubule, leading to almost 90% reduction in the filtered glucose. And that is why all this glucose is excreted in the urine, resulting in glycosuria and excess calorie, which has been excreted through urine. And this is the predominant glycemic reduction mechanism of action of SGLT2 inhibitors. If we see the pharmacological properties, pharmacokinetics and pharmacodynamics for the 3 most commonly used SGLT2 inhibitors and approved by FDA, empagliflozin, dapagliflozin, and canagliflozin. So therapeutic doses, of course, they vary. There are 5 to 10 milligram for DAPA, 10 to 25 for EMPA, and 100 to 300 for canagliflozin. But usually, more or less, pharmacological properties are not much different among these 3 SGLT2 inhibitors. If we say all these 3 are having an T half-life of more than or around 12 hours, so that they are, all the 3 are given once in a day with or without food, and more than 60% is the bioavailability for all these 3 agents. Again, if we see the metabolism, they are excreted as an inactivated glucuronidized product through urine, through kidneys or through liver, and there are no active metabolites of it. Both hepatic as well as renal pathways of elimination exist for these 3 drugs with variable rates of excretion through kidneys and urine. And if we see the selectivity of these agents for SGLT2 versus SGLT1 receptors, then we can say more or less they are, all these 3 are highly selective SGLT2 receptor inhibitors with very mild or negligible SGLT1 activity. Let me tell you, SGLT1 are the predominant receptors in the gastrointestinal tract to lead to glucose reabsorption, and while the SGLT2 are the predominantly exist in the renal proximal tubules. And if we see the excretion of the glucose with the higher doses of these particular drugs, around varying from 70 to 120 milligrams of the extra glucose is excreted through the kidneys with the increase in the drug dosages. Now, moving on to the efficacy of the empagliflozin, which we are going to discuss in today's first session. If we see the pooled data from the one of the phase 3 randomized control trial in terms of empagliflozin and reduction of the HbA1c, and what is the change of HbA1c from as compared to baseline. So these are the 2 groups. One is that blue one is the empagliflozin 10 milligram, and the red one is empagliflozin 25 milligram. And we know that, and it has been shown in this particular study, that increasing the dose of empagliflozin from 10 to 25 milligram results in higher HbA1c reduction, or more HbA1c reduction. Again, the HbA1c amount of HbA1c reduction with the 10 or 25 milligram, again, it depends on the baseline HbA1c and the baseline anti-diabetic medications, what other anti-diabetic medication or insulin is going on. But on an average, we can say that if it is given as a monotherapy, 0.85 or up to 1% of HbA1c reduction is expected in most of the studies, but it varies according to the existing medications. So other than HbA1c reduction or glycemic reduction, today's session is mainly for, I think it's for pleiotropic effects of empagliflozin. That is the effect on the body weight reduction, effect on the blood pressure reduction, and mainly cardioprotection and heart failure reduction. So if we see the body weight reduction, because empagliflozin and other SGLT2s results in the glucosuria. So as I said, excess of calorie is excreted through the urine, and it is insulin independent mechanism of action. That is why it results in a decrease in the insulin levels also, and that is why it results in weight reduction. So again, weight reduction, similar to HbA1c reduction, it depends on the baseline weight and what other kind of medications which are going on. But on an average, 1.5 to 2.5 kilograms of weight reduction is expected in controlled studies in phase 3 trials. Similarly, if we see the blood pressure reduction, systolic blood pressure reduction also, it increases with increasing the dose of empagliflozin depending on the prior existing anti-diabetic medications. So this is a very beautiful curve showing the ambulatory blood pressure monitoring over the 24 hours. That is, hourly blood pressure values are there for complete 24-hour periods. And the three groups were there. One where the two doses of empagliflozin 10 mg and 25 mg, they were compared to placebo. Placebo, which means all other antihypertensives were continued. So here we can see that when EMPA and 10 and EMPA 25, both the doses resulted in a significant blood pressure, systolic blood pressure reduction throughout the daytime, except in the last 4 or 5 hours, where the blood pressure reduction equals with all the three groups. So almost more than 16 to 18 hours in a day, both the EMPA doses group resulted in a significant systolic blood pressure reduction as compared to placebo. And the same was the case for the diastolic blood pressure reduction at the end of 12 weeks of treatment initiation with both the doses of empagliflozin. As I said, there are some changes in the lipoprotein profile, plasma lipoprotein profile with the empagliflozin and other SGLT2 inhibitors as well. Broadly, it results in increase in the LDL cholesterol as well as increase in total cholesterol. But the more beneficial one is it also results in significant increase in the HDL cholesterol. If we see from baseline, as compared to placebo, there is a significant increase in the HDL cholesterol with 10 milligram as well as 25 milligram. And similarly, it also refines both. But reduction in the triglyceride with the 10 milligrams of empagliflozin is found to be statistically significant. But again, just let me revise it that the cardioprotection obtained with the SGLT2 inhibitors appears to be independent of changes in the plasma lipoprotein levels. So this is just a brief table of effects of the SGLT2 inhibitors on these three parameters which we discussed in the phase 3 trials, that is glucose control, that is HbA1c control, body weight reduction, and systolic and diastolic blood pressure reduction. Variable parameters are there, and all these depend on two parameters, as I said, baseline weight or baseline A1C, and the other existing anti-diabetic and anti-hypertensive medications. So after looking into the efficacy of the SGLT2 inhibitors in the HbA1c reduction, weight reduction, and blood pressure reduction, next question comes to our mind is the tolerability and the safety issues with these agents. So if we see the safety or tolerability of the SGLT2 inhibitors, it is comparable to placebo. There are no tolerability issues as such. Percentages wise, the SGLT2 inhibitors 10 and 25 resulted in lesser tolerability issues as compared to placebo, statistically not significant. So we can say equal or statistically not significant, equal tolerability issues, and no such intolerability issues, and none of the leading to discontinuation of these drugs. If we see the adverse events leading to discontinuation, again comparable to placebo, and if we see the serious adverse events, same with the placebo, comparable. But what concerns to us when SGLT2 inhibitors or empagliflozin comes to our mind, we think of urinary tract infections and genital infections. So here in this data published in ADA 2015 by Professor Kohler et al., it has been mentioned that urinary tract infection on an average, it was not statistically significant between both the doses of empagliflozin as compared to placebo, 9.3 versus 10%. So more or less UTI risk is not increased with these, provided I would just again add that selection of the patients is more important. The patients who are having an hydronephrosis or obstructive uropathy, of course, they should be excluded to prevent the risk of urinary tract infections. But again, otherwise, this trial has not shown any significant increase in the UTI risk in both male as well as females. Pyelonephritis and severe urosepsis, if we consider, the risk is very low, less than 0.1%. That is just similar to placebo. But the more concerning is the only genital infections. The genital infections, they were significantly higher as compared to placebo in both the doses of empagliflozin. And for this, I just advise to give hygiene advices to the patients to maintain the personal hygiene and intimate hygiene. So that is the only measure we can avoid or we can prevent these genital infections. They are not much of a big concern in my routine day-to-day practice with the empagliflozin. Otherwise, if we see volume depletion or number of patients having hypoglycemia or severe hypoglycemia, again, these are same comparable to placebo. There is no such issues with volume depletion or dehydration related to this. So the talk of the town or talk of today, again, we can say the cardioprotection of with empagliflozin and other SGLT2 inhibitors, if we say. So EMPA-REG outcome trial was the first of its kind of cardiovascular outcome trial to show the decrease in the cardiovascular death related to all-cause or 3-point MACE or decrease in the heart failure related to diabetes. So it was the first trial to show the reduction in the cardiovascular death from diabetes. So we'll just briefly discuss. Also, it showed the betterment of the renal parameters or renal outcomes, which include incident or the worsening nephropathy, progression to macroalbuminuria from microalbuminuria, and overall composite renal outcomes. All of these three parameters, they were statistically significant as compared to placebo in patients who were on empagliflozin arm. So other than these renal parameters, as I said, and we know that the patients with type 2 diabetes in the EMPA-REG outcome, it showed that empagliflozin given in addition to the standard of care, it resulted in a reduction in the heart failure hospitalization, reduction in the cardiovascular death, as well as a consistent benefit observed in both who were having heart failure at or established heart failure or without heart failure at baseline. So in all these patients, reduction in the cardiovascular death as well as the overall cardiovascular risk factor reduction was observed in the patients with empagliflozin arm as compared to placebo arm. In the same trial, EMPA-REG outcome trial, we can see from this forest plot that this 3-point MACE reduction as well as the cardiovascular death reduction, they were statistically significantly low in empagliflozin arm, and it favors the empagliflozin as compared to placebo, while the non-fatal MI and non-fatal stroke, they were not significantly different between these two arms in the EMPA-REG outcome trial. So now after looking into the benefits in terms of cardiovascular risk reduction and heart failure reduction, the next question is how early we can achieve these cardiovascular benefits with empagliflozin as compared to placebo. So again, from the same trial, EMPA-REG outcome trial, it showed that the curves for these or the cumulative incidence curves for the EMPA versus placebo, they separated very early in the treatment period. And it was within weeks after initiation of the treatment with either empagliflozin or placebo, and that these benefits were evident. If we see in this particular graph that risk reduction of hospitalization for heart failure with empagliflozin versus placebo, it was achieved as early as day 17. So by day 17, the heart failure risk reduction was statistically significant as compared to placebo. While if we see the cardiovascular death or the cardiovascular death reduction, it was evident and it was statistically significant by day 27, and it persisted throughout the study period. So the cardiovascular benefits are achieved very early in the treatment initiation, and they are continued throughout the treatment with empagliflozin in these trials. So, and the another one of the trial, that is EMPA-REG study. EMPA-REG study is yet to complete and yet to come with the full results, but the interim analysis of the patients or the EMPA-REG study, which compared the patients enrolled in randomized into the either empagliflozin or into the DPP-4 inhibitors. And in the interim analysis, again, these are the interim studies, and still it is showing that heart failure risk reduction as well as the all-cause mortality. They were significantly lower in the empagliflozin as compared to DPP-4 inhibitors, while the myocardial infarction and stroke risk were similar as of now. But still, I would say we will await the final results of this particular trial. Just to brief or just to mention the cardiovascular outcome trials. Again, let me tell you, cardiovascular outcome trials, they were recommended by the FDA USA that any new anti-diabetic agent to be introduced into the market, it has to undergo through cardiovascular outcome trials to be approved by FDA, and it should show the cardiovascular safety over placebo. But rather than cardiovascular safety, SGLT2 inhibitors, especially empagliflozin and one or some of the GLP-1 analogs, they have shown cardiovascular risk reduction over and above the cardiovascular safety and glycemic reduction. So these upper ones are the cardiovascular outcome trials for DPP-4 inhibitors. These green ones are the cardiovascular outcome trials for GLP-1s, and red ones are cardiovascular outcome trials for SGLT2 inhibitors. So at the end, I would just like to show this flow chart recommended by ADA and EASD, that is American Diabetes Association and European Association for Study of Diabetes, a consensus report published in 2018. Even today and by then also, metformin has been considered a first-line drug therapy for people with type 2 diabetes mellitus. Even today, I would say it is considered to be a first line. I also prefer metformin to be the first line. But for the first time in 2018, ADA EASD consensus report said that it should not necessarily be considered first line. Definitely it is first line, but again, in patients who are having atherosclerotic cardiovascular disease or who are having high risk or very high risk of cardiovascular disease, SGLT2 inhibitors or GLP-1 receptor agonist with proven cardiovascular benefit, it should be started and it should be considered equal first line anti-diabetic agent for starting the patients with type 2 diabetes mellitus. So with this, I would like to end my session here. And in the next part of the presentation, I think Dr. Kapil Virpariya sir is going to elaborate the cardiovascular benefits and the mechanisms of it. Thank you so much. Over to you, Dr. Lokesh. And we'll hear from Dr. Kapil sir. And at the end of the session, I will be there with Kapil sir to answer the questions if there are.
Yeah. So there will be usually questions from the audience will be there. So thank you very much, Dr. Kunal, for sharing your insights. Very interesting. Now I would like to request Dr. Kapil's cardiologist, Dr. Kapil Virpariya sir, to share his insights from cardiology perspective. So good evening, sir. Welcome to the meeting.
Yes, good evening, everybody.
Doctor, can you please share your slides, sir?
Yes, I'm doing. My slides are visible or still not?
Make it on
Slides are visible. So you can make it into a full slideshow mode, sir.
Achha, slides are visible. No?
Yeah.
Yes, sir. Your slides are visible, but make it on full screen.
Now it's okay. Visible or?
Okay. Yeah, now it's perfect. Make it on slideshow mode. Perfect, sir.
Good evening, everybody. After such a wonderful discussion by Dr. Kunal, now my topic is regarding the cardiovascular benefit. till now we had many anti-diabetic drugs, but all drugs are either cardiovascular neutral, or it has a negative results. While the SGLT2 inhibitor are the first group of the drugs which shows a significant cardiovascular mortality as well as morbidity benefits. And based on this, now this drug are drugs of the multi-millionaire drugs. Uh, the we had the among the three different SGLT2 inhibitors, the cardiovascular benefit, the heart hospitalization for heart failure reduction is seen maximum with empagliflozin 35%, followed by CANA, followed by DAPA. The CV death reduction is maximum by EMPA 38%, while the all drugs are relatively equally nephrosafe. Nephroprotection is almost similar with maximum nephroprotection by DAPA. The EMPA-REG outcome trial. The EMPA-REG outcome trial was a large randomized control trial, empagliflozin versus placebo. And in this trial, we can see from this bar diagram, the death from CV death reduction is significantly more in a EMPA group as compared to placebo group. And not only CV death, we can see also death from any cause is also lower, significantly lower in EMPA group. Effect of the more or less intensive glycemic control or on MI. The debate is whether to intensive glycemic control versus less aggressive control. The mainly we know, if we do a more intensive glycemic control, means HbA1c less than 6.5, in that case we get a microvascular benefit from the reduction of the microvascular events from the diabetes. But the main concern was cardiac. And among this trial, the Accord trial, which shows more intense glycemic control, lead to more cardiac mortality. These are the various trial which shows heart failure outcomes. And in this trial, the most of the drugs are either neutral, or it has a it has a more adverse effect for heart failure. From the UKPDS study, sulfonylurea is almost neutral for heart failure. In Origin study, insulin is neutral, while the studies of the thiazolidine, pioglitazone as well as rosiglitazone shows more heart failure with glitazones. The similar GLP-1 analogs, these are the neutral agent as far as the heart failure hospitalization is concerned. The same DPP-4 inhibitors are also neutral, while the SGLT2 inhibitor are the group of the drug which shows significant improvement, a significant positive result for a hospitalization for heart failure. Be it a EMPA-REG trial for empagliflozin or DAPA-HF trial for dapagliflozin. Both trial are very positive to reduce hospitalization for heart failure. In the EMPA-REG trial, the large randomized control trial, which was against the placebo. In this trial, there was three subgroups: the placebo, EMPA 10 milligram as well as EMPA 25 milligram. And the patients were included was very high risk patients, so type 2 diabetic patient with established cardiovascular disease. And in this trial, the hospitalization for heart failure was significantly reduced in EMPA group, as we can see from this table, this chart, the benefit is, we can see early, as earliest benefit seen within 3 months, and the curves start more and more separating uh, as the time goes. So the benefit of the empagliflozin start earlier for prevention of the heart failure, and we can get a sustained benefit if we give for a longer period. As the Dr. Kunal already discussed, these are the multiple pleiotropic mechanisms which lead to reduction in the heart failure hospitalization. As we know, SGLT2 inhibitors inhibit sodium glucose co-transport in a proximal tubule of the kidney, so it reduce sodium. It prevent a sodium and glucose reabsorption. So it has a natriuresis effect as well as osmotic diuretic effect. So it reduce it lead to the natriuresis as well as reduce interstitial edema by osmotic diuretic effect. So it reduce a preload, and it also has a direct renoprotective effect. So it improves the cardiorenal physiology. By improving cardiorenal physiology, it helps to prevent heart failure, and it also has a direct cardiac positive effect on cardiac myocytes also. So these are the pleiotropic effect which, by which this mechanism, the SGLT2 inhibitors, uh, helps to heart in heart failure. And also there are some unknown mechanisms by the SGLT2 inhibitors has a cardiac role, positive cardiac role. We had the many medications which either prevent or treat the established heart failure. We had statins, statins, calcium channel blocker, thiazide, SGLT2 inhibitor, antiplatelets, which prevent heart failure. We had a wonderful drug. This is sacubitus valsartan, ARNI, helps to treat established heart failure. We had a ivabradine, we had a CRT, ICD, we had a mineralocorticoid receptor antagonist. These are the agents used only to treat established heart failure. Well, we had some therapy which helps in both way, like AC inhibitors, ARBs, beta blockers, as well as SGLT2 inhibitors. Uh, what the guideline says. Previously, the guideline says was monotherapy was a first line drug. Metformin therapy should be considered first line therapy for each and every diabetic patient. But the recent 2019 ESC guideline says monotherapy metformin is not a first line anti-diabetic drug for every patient. We should calculate risk. If the patient's calculated risk is high or very high, or established atherosclerotic cardiovascular disease, then this we should start directly SGLT2 inhibitor to this patient. If the patient has a moderate or low cardiovascular risk, like the new onset diabetic patient, and in this case we should start metformin therapy. Otherwise, if the patient has a high risk or very high cardiovascular risk, then the first drug to start in a diabetic is a SGLT2 inhibitor. While the ACC-AHA guidelines still consider metformin as a first-line therapy, and if the still HbA1c is more than or equal to 7%, then we can consider SGLT2 inhibitor. The ESC guideline recommend SGLT2 inhibitors as a first line for a high or very high cardiac risk patients because of the cardioprotection. The second trial, which is a EMPA-REG heart failure studies, this trial was divided into the two part, EMPA-REG reduce as well as EMPA-REG preserve trial. In reduce, EMPA-REG reduce the subgroup, the empagliflozin was given to patients with ejection fraction less than or equal to 40%, while in preserve trial, the empagliflozin was given to patient with ejection fraction more than 40%. And in both this, in the EMPA-REG trial, the patient should have a elevated cardiac biomarker NT-proBNP, and while for the reserve group, the along with the NT-proBNP, patients should have at least one of the following, like structural heart disease, or patient has history of hospitalization for heart failure within 1 year prior to screening. In both trial, the 10 milligram empagliflozin was given against the placebo, and as we can see, this is a very large randomized control trial, participants participating around the more than 4,000 patients. And this trial was a multicentric trial, including the Asia Pacific region, like the Indian population was also included in this trial. This trial was basically to determine the efficacy and safety of the empagliflozin in patients with heart failure with reduced as well as heart failure with preserved ejection fraction. From the EMPA-REG trial, we saw the beneficial effect of the empagliflozin in a high cardiac risk group patient. This trial was specifically designed for patients with established heart failure. The conclusion of this trial was empagliflozin beneficial in heart failure with reduced ejection fraction with or without diabetes. So in this trial, 50% of the patient was diabetic, 50% patient was without diabetes. So the empagliflozin reduced CV death as well as hospitalization for heart failure in a both subgroup, patient with diabetes as well as patient without diabetes. So empagliflozin can be given in patient with low EF with clinical evidence of the heart failure, even without diabetes. The message is loud and clear. Cardiovascular and renal outcome with empagliflozin in heart failure. EMPA-REG trial, this cardiac and renal outcome. In the EMPA-REG trial, the primary endpoint was a composite endpoint of the cardiovascular death or hospitalization for heart failure. The secondary endpoint was a total heart failure hospitalization, and the secondary endpoint was a slope of the decline in glomerular filtration rate. As the Dr. Kunal already said, the SGLT2 inhibitor not only have a cardioprotection, also have a nephroprotection. So in this trial also, the nephroprotection was also evaluated. In this trial, the patient more than 18 years was included chronic heart failure. As we discussed, ejection fraction in the EMPA-REG trial, ejection fraction was less than or equal to 40% with history of heart failure, hospitalization within 12 months, and positive NT-proBNP. Patient with acute coronary syndrome, stroke, or vascular event like transient ischemic event was excluded. Valvular heart disease, infiltrative disease patients was excluded, and patient with acute decompensated heart failure patient was excluded. So this in this trial was a trial of heart failure patients. In this patient, as we can see from this slide, 50% patient was diabetic, 50% patient was non-diabetic. By this slide, we can say there is a 25% risk reduction in composite cardiovascular death or hospitalization for heart failure, 30% risk reduction in total heart failure hospitalization. Second endpoint slope of the decline in glomerular filtration rate is 50%. By this, chart, we can say the total hospitalization for heart failure first as well as second event was significantly lower in EMPA group. And as we can see, curve starts separating early, so we can get benefit less than 3 months, and the benefit is sustained over a period of the time. Does the empagliflozin lower a risk of the CV death or hospitalization in patient with heart failure? Obviously, yes. There is a significant reduction in a heart failure hospitalization as well as cardiac death. The interpretation, the result of this trial indicate that empagliflozin is superior to placebo among the patient with symptomatic stable heart failure with reduced ejection fraction on baseline guideline directed medical therapy irrespective of the diabetes. In this trial, the most of the patient was on baseline guideline directed medical therapy. So most of the patient was on beta blocker, S inhibitor, or ARBs or ARNIs, as well as mineralocorticoid receptor antagonists. So in this trial, apart from the baseline guideline directed medical therapy, this patient was given added given to the empagliflozin by the DAPA-HF as well as this trial. We can say the NAVE, empagliflozin as well as the dapagliflozin are the drug we can add as a anti-failure therapy along with other medications, which safely without any major side effect, without any significant volume depletion, without significant worsening of the renal failure, or without significant sepsis. Only the asymptomatic bacteriuria, as the Dr. Kunal said, asymptomatic bacteriuria is more common, but serious sepsis is not more common in this group. So this is a very safe drug, which this SGLT2 inhibitor doesn't reduce blood pressure. We can simply add these medications to our existing heart failure medications, and it uh, reduce a 20 to 30% the cardiovascular risk without significant side effect. And the best thing is we don't need a more monitoring if we add this drug. If we add the other anti-failure drug like ARNI or ACE inhibitor or ARB, we should monitor creatine and potassium. If we add this drug, we need not to monitor aggressively, because these are the relatively benign drug with very uh, without a significant more serious side effects. The benefit is primarily driven by reduction in heart failure hospitalization. Our main aim to reduce morbidity in heart failure is to reduce heart failure hospitalization. We knows if the patient has a hospitalization for heart failure, it increase the economic cost burden, as well as it increase the mental psychological trauma to patients. So the main primary input is driven by reduction in the heart failure hospitalization, and our aim is to reduce hospitalization for heart failure to this type of the patient. And also the NVHA class improvement is also seen with this drug. So this not only reduce heart failure hospitalization, also helps to improve the patient's the NVHA symptom. There was also benefit in renal outcome. This is a very important trial and mirror a similar finding from the DAPA-HF trial with dapagliflozin. So till this results of this trial, we had an option of the dapagliflozin. Now, after the such a great result of this trial, we had now the option of the empagliflozin. And the great thing is, in this trial, the used dose was a 10 milligram, not a 25 milligram. So lower dose is also give a more cardioprotection. While in a DAPA-HF trial, the dose was a 10 milligram. In this trial, the dose is 10 milligram. So this is a lower dose of the empagliflozin, while in the DAPA-HF trial, the dose used was a upper 10 milligram dose of the dapagliflozin. Even in patient with severe LV dysfunction appear to be beneficial. Even through SGLT2 inhibitor was introduced as a anti-diabetic drugs by this trials, the and other indicate clear benefit in also management of the heart failure. So after this trial, we can say we had a one more molecule in our armory of for managing the heart failure. This trial enroll a dedicated heart failure population and conclusively shows benefit irrespective of the diabetic status. This drug will likely to have a prominent role in future heart failure management. These are the speculated mechanisms as we already discussed. Thank you.
Thank you, Dr. Kapil, for sharing your insights. We have a couple of questions from the audiences. Dr. Kunal, yeah. So, first question from the audience is, in case of heart failure, so we have both dapagliflozin and empagliflozin. So, based on the data that is available till now, so which should be the first preference?
Okay, if we compare dapagliflozin and empagliflozin, I think there should not be, there is no difference in the data which are available in literature and in the clinical practice also. I don't think glycemic efficacy or the heart failure risk reduction, which appears to be different between the two, any of these two drugs are safe to initiate in patients with diabetes and history of heart failure. As far as overall cardiovascular death is concerned, empagliflozin has shown an edge over dapagliflozin. But for heart failure in diabetic patients, I would suggest, as per the data, both are safe. Clinical experience related to heart failure in patients and which medicine to be started in patients without diabetes or with diabetes, I think Dr. Kapil sir would answer more based on his practice.
Dr. Kapil, your views, please, on this question.
No, my personal experience with both drugs are very good. Not only mortality benefit, but I see the class NYHA class improvement. The patient feels better even after the 1 month of the starting of this both molecules. So both are superior. We can't compare head to head both molecule as far as the yes, in my practice, if the patient without heart failure, only patient has a high cardiovascular risk. Based on the EMPA or the trial data, I preferred empagliflozin over dapagliflozin. If patient without heart failure, only diabetic patient with with established coronary disease. So if the patient come to me with a myocardial infarction and he or she is a diabetic, without the clinical feature of the heart failure, I prefer empagliflozin. But if the patient has a clinical heart failure, then we had a data of the both drugs equal. But if
Okay.
without heart failure, only the diabetic patient with established atherosclerotic vascular disease, then the EMPA is better than DAPA because we had a solid evidence. So we had the data from the EMPA trial.
Okay. Okay. So second question is, there is SGLT2 inhibitor, then there is GLP-1 analog. So in case of diabetes patients, so with ASCVD, and in case of ASCVD, which should be the first choice, and in case of diabetic patients with heart failure, which should be the first choice?
Yeah, so diabetic patient with ASCVD, again, we discussed, Dr. Kapil sir also said that cardiology guidelines as well as diabetes guidelines are showing if ASCVD, you start either SGLT2 inhibitor or GLP-1 analog, whichever is that. But if there is heart failure, then only SGLT2 inhibitors have shown to reduce the heart failure because of multiple mechanisms, natriuresis among others. Because GLP-1 analogs, they are not known to reduce the heart failure risk or especially in patients with reduced ejection fraction. But without heart failure, any of these drugs are okay. With heart failure, SGLT2.
Okay, so can these two drugs be used in the same patient simultaneously?
Yes, they can be used. SGLT2 or GLP-1 can be used with any other anti-diabetic agent or with insulin.
Okay, okay, okay. So Dr. Kapil, your views on this?
Yes, these both drugs can be used, and rather, if the patient is affording, then both drug give the synergistic additive effect. because the mechanism are the both drugs are different. So we definitely can use both drugs.
Okay. So, last question. So, what should be the cutoff EGFR level for starting SGLT2 inhibitors?
All the three SGLT2 inhibitors and the trials, the data is available. They are showing that SGLT2 inhibitors, they are effective to the best potential when the EGFR is more than 60. But even up to EGFR of 30, we can use EMPA or Empagliflozin, and for DEPA, I think there was a cutoff of EGFR 45 according to the earlier declared trial, and then they have shown the benefit of DEPA in EGFR up to 30 also. So up to 30 of EGFR, I think we can use the SGLT2 inhibitors. Below 30 EGFR, there is no harm in giving SGLT, but there is no effect, or the effect of the SGLT2 inhibitors has been reduced because there is no glomerular filtration. And when the medicine is not filtered, it is not going to act on the primary proximal tubules. So up to 30 of EGFR, they are equally effective.
Okay. Okay. So, Dr. Kapil, would like to agree or add something to this? Yeah.
No. Dr. Kunal has explained very well the basic, the funda of the giving medicine more than 30 EGFR. And
Okay.
in the whole trials, the same cutoff was taken. So EGFR should be at least 30.
Okay. Okay. So there are no more questions. So with this, we come to the end of the session. So thank you very much for two exceptional talks. The audience would have thoroughly enjoyed these talks, and that these talks might have enlightened more on the topic. So from Lupin, we are extremely thankful for accepting our invitation and being part of this event. From my side, have a great week ahead and good night.
Thank you so much, Dr. Kapil sir, and thank you, Team Lupin and Dr. Lokesh sir, for including me and letting me share the stage with Dr. Kapil sir, and was a wonderful session. Thank you so much.
Thank you very much. Yeah.
Dr. Kunal, your talk was wonderful, and it was your presentation, uh, 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 the way of the presenting the slides were very good. I say I enjoyed the talk was very good.
Thank
Okay.
you so much, sir. Thank you. So nice of you. Thank you so much. I also enjoyed the scientific content you provided. Yeah. Thank you
Because
so much.
basically it's anti-diabetic molecule, so the small mechanisms. Being a cardiologist, we are not knowing that thing. I know today.
Right, sir. Right. So that anti-diabetic medicine is now being cardiologist medicine, more or less.
Yeah.
Okay.
Okay.
Good night.
Yeah.
Thank you, everyone.
Thank you. Thank you very much.
Sufyan, you can end the session.